All right. Hello, everybody. This is Munira. I am a pelvic health physiotherapist with a very special interest in women's health and specifically diastasis rectus abdominis and abdominal wall dysfunction postpartum. And today I am joined here by Dr. Jamie Moenster, who is a board certified plastic surgeon. And today what we're going to be doing is talking all about surgical repair of diastasis recti. So thank you so much, Jamie, for being here and for just giving us some of your time. What I'd like to do is just kind of let the viewers know a little bit more about you and just read over a little bit of a bio. So Dr. Moenster graduated from Kirksville College of Osteopathic Medicine in Missouri. She then completed 5 years of residency in general surgery and 2 years of fellowship in plastic and reconstructive surgery at South Point Hospital, also part of Cleveland Clinic Health Systems. She served as the chief resident in both general and plastic surgery. Dr. Moenster is board certified in plastic, reconstructive, and general surgery by the American Osteopathic Association and the American Osteopathic Board Surgeons. And she is also a fellow of the American College of Surgeons. She received the General Resident Achievement Award by the ACOS in 2010. She was also awarded the Core Resident of the Year and Skills Lab Instructor of the Year. She is on staff at Northwest Medical Center, Canyon Vista Hospital, and Northwest Tucson Surgery Center. Wow, that is a pretty impressive bio, Dr. Moenster.
Oh, thank you. So I practice here in Tucson, Arizona, performing plastic surgery, and one of my number one procedures is abdominoplasty with diastasis recti repair. So
is that right?
This is something that's important to you. It's something that I see a lot of, and I think there's a lot of misconceptions about what it is, how it's treated, how it's functioned, and even my role in treating a diastasis.
Oh yeah, I totally agree with you. There is a lot of information, but within that, there's a lot of misinformation too. So I really hope what we're doing together right now will help to just to provide some clarity amongst all the information that is out there for women who have diastasis, who have questions and concerns about getting surgery or getting it treated surgically, and also for a lot of the rehabilitation and fitness professionals who have a lot of questions too.
Yes.
So yeah, again, thank you. And just in case whoever is watching and listening isn't already aware, so the reason why this interview has sort of come about is because there have been so many questions kind of coming in my way regarding surgery. And it's diastasis in general right now is a hot topic. And specifically because of that, there are more questions about when is it appropriate to get surgery, when, what does that look like, what are the different kinds, and so many questions. So what I had done is I asked all of my own Instagram followers if they wanted to know anything about surgery, what would they want to know? And really within about less than 24 hours, over 100 questions were submitted. So what I ended up doing is sort of reviewing them, combining them and compiling them. And there were quite a few repeats as well. So that was, which shows which areas people really were more interested in. And the 3 areas that I think were the most asked about were hernias, more about intraoperative considerations like different kinds of suturing techniques, and the other one was about complications and also like just post-op, some the outcomes and complications. So we'll dive into all of that over the course of this interview.
Yes, I'm looking forward to helping provide some education. And again, this is something that I deal with a lot as well as have a personal interest in. And so it's interesting, as I got the questions from you, I get similar questions from my Instagram and Facebook followers as well, and also from my patients when they come in to see me in consultation.
Yes, okay. Oh, so I can't wait to just get your expertise on all of this. So maybe we'll just begin and we can potentially just start talking about what is an abdominoplasty, what exactly happens in that surgery, and And or is it different from a diastasis recti repair? Are they different things? Maybe you can go ahead and talk about that.
So diastasis recti repair is a very traditional part of a tummy tuck surgery. It is usually included in most full abdominoplasty or tummy tuck surgeries. And a tummy tuck surgery really is a descriptor that explains a postpartum makeover or maybe a massive weight loss makeover. And this is usually removal of excess skin, tightening of the diastasis recti muscle, and creating a new hole for the belly button. It may also include liposuction and or a hernia repair if needed.
Okay.
And that is really kind of the full abdominoplasty.
Okay.
So we're going to talk a little bit about mini abdominoplasty, which may not contain all of those components. A question I often get as well is, can a diastasis recti repair be done without a tummy tuck? And the answer is yes.
Okay.
However, usually still have to redrape the skin. We think about corseting the muscles together. If we left the skin, there'd be a big bulge, which we definitely don't want to see.
Right.
And so
okay.
We have to redrape the skin as we bring those muscles back together.
Understood. Okay, I never thought about that. So is that also the case for a mini diastasis recti repair?
So typically with a mini, for most surgeons, a mini abdominoplasty or a mini tummy tuck includes basically from the belly button down. And usually the tightening then is just from the belly button to the pubic bone. However, as you know, there are a lot of different ways diastasis presents. And sometimes it's below the belly button, sometimes it's just above the belly button, sometimes it's below and above, right at the belly button. And so if you have a lot of diastasis above the belly button, it's typically not the best option for patients, because we do usually want to tighten the whole thing. And so it also depends on how much excess skin is there for each individual patient.
And I'm just, is it right for me to assume that the amount of skin or maybe even lack of excess skin also determines what the actual incision would look like? Because from what I understand is if there's not enough skin to pull down from, that you might also have like a little sort of vertical line from the main incision going up. And so do you mind just talking a little bit about that?
So typically when there's enough skin to get the skin from above the belly button down all the way to above the pubic bone, and the traditional tummy tuck ranges about 7 centimeters from kind of the vaginal verge, so where the two outer labia of the vagina. And so about 7 centimeters above that. And so we're trying then to get the skin from above the belly button all the way down to there. Not everyone has enough laxity to stretch, and occasionally you'll end up with a T-scar or a very small scar where the belly button was removed that ends up above that hip-to-hip incision.
Okay.
The goal of the very low hip-to-hip incision is to keep the incision hidden from a two-piece swimsuit or even in natural undergarments, to keep that incision concealed. Another question that gets asked a lot is about the length of the incision, and obviously if there's more excess skin, or the skin that's excessive goes past the hip bones, the incision typically has to go further as well.
Okay. So there can be variations in the actual incision, the scar length, and the scar appearance. So what considerations would you be talking over with someone who is coming in and presenting with to you with diastasis, specifically regarding getting liposuction in addition to that, or other things that they might be concerned about, such as breast augmentation or changes in other areas in addition to just the diastasis repair? Because I have a feeling from, again, my research that women might actually be interested in getting multiple things done at once in the one surgery. So would you mind talking a little bit more about that?
Sure. You know, the common term we hear a lot is mommy makeover, and it's a catch-all term that usually is a goal of bringing back body post-baby for both the breast and the tummy. And that can include liposuction or a tummy tuck or a mini tummy tuck for the belly. And
Okay.
then for the breast, it could be implants or a lift or a reduction or a combination of those treatments. Typically for me and for most surgeons, it's a good thing to do these cases together because it's a simple recovery, it's less downtime. It also tends to be less expensive for the patients when you bundle procedures.
Okay.
There are some limitations again for timing. So we typically don't want to do super long surgeries that last about more than 6 hours for most surgeons, maybe 7 hours for some.
Okay.
I kept myself right around that 6 hour mark. I think it's the safest for the patient. It's also when I can perform my best. When I get beyond those 6 hours for one case, I start to get a little fatigued and I feel like I can give my best to the patients. But
Yeah, completely understandable.
definitely something that, again, after children, we see changes in more than one area of our body, and breast and tummy tend to be the two main ones for most women.
Right.
So it's definitely safe to do those things together.
Okay.
But of course, it's very individualized. Obviously, other health concerns, any prior existing medical conditions. And then, of course, then budget plays a role because these things are typically not covered by the health insurance.
Right. Okay. So I guess that leads me to ask, how much would a typical diastasis recti repair cost without liposuction and then with liposuction? And I'm also including an abdominoplasty as part of that procedure.
Sure. The prices really vary based off of the region. The experience of the surgeon plays a role. The average for a mini tummy tuck to a full or extended tummy tuck can vary anywhere from about $3,000 in US to about $10,000 US. And that can include with and without liposuction. In my practice, I do include liposuction of the waistline and the upper abdomen. And if I don't include liposuction, I consider that part of a mini because I'm not doing all of
Oh, okay.
Now, that is not what every surgeon does, but that's my personal practice. That is kind of the price range, and that also then can include your anesthesia and the facility fee. So typically with surgery, there are a couple different kind of price points. There's the surgeon's fee, which covers the actual surgery portion. There's the facility or the hospital fee, which covers the place where the OR is, the nursing staff, the medications that are given during the surgery. And then there's typically a third fee for anesthesia. And of course, sometimes if there's an implant like a mesh or a breast implant, there's a fee for that as well.
Okay. Okay. So around 3,000, minimum $3,000, but it could be upwards of $10,000.
With the average being in that 5 to 7 range for most of the regions in the United States.
Okay. And this is probably a question you get asked a lot as well, but is there any kind of medical diagnosis that someone would be diagnosed with where this kind of surgery could be covered under insurance? Something like hernia or low back pain? Excuse me.
So hernias are a medical condition that are typically covered by the health insurance. A hernia basically is a hole in a layer where contents from one area push into another. If there is a hernia, typically the hernia portion can be covered, but it wouldn't cover any of the additional parts of the abdominoplasty.
Okay.
The other thing that we sometimes see in massive weight loss patients is what's called a paniculectomy, or a below the belly button skin only tummy tuck. And those are patients who have lost greater than 80 pounds, patients who have skin that hangs below the pubic line. So basically the entire genitalia has to be covered by the skin.
Okay.
And presenting with medical conditions that do not respond to conservative therapy. So rashes of the skin or infections of the skin that don't respond to antibiotic pills or prescription creams. And so there is definitely a hierarchy to get that covered. But again, that only then covers the skin below the belly button.
Okay, understood. Okay. So it's
go ahead. In the United States right now, diastasis recti is a diagnosis, but it is not considered medically necessary by the insurance companies for repair.
okay.
But we do see significant improvement in back, hip, and pelvic pain, as well as sometimes improvement in bowel and bladder function.
Okay, that is really good to hear. And I guess we'll talk about that in a little bit, but yeah, just regarding the outcomes of surgery, if these women are coming in with back pain and or pelvic floor dysfunction or pelvic conditions, incontinence, for example, and they're getting an improvement in these symptoms after having the surgery, is there some way to almost build a case of that? Like maybe for the insurance company so that they could eventually, at like later on down the line, potentially cover something like this. Because I think, yeah, just like you were saying, a lot of it really is just coming down to it being considered more or less cosmetic, whereas I strongly believe that a lot of this is contributing to women's symptoms. And yeah, I'm hoping that there's somehow going to be a way to get some of these things addressed and covered.
Yeah, and
More
I think
people will be getting the surgery than I think, because just of the cost barrier.
yeah, and really the way to do that would be blinded independent research studies that are basically screening for those things both before and after surgery, and things like MRI or pelvic floor pressure studies, urologic studies that are going along with these cases. And so, you know, we hear a lot of anecdotal evidence, meaning that patient will come to you and say, hey, after my surgery, I have noticed that my back and hips don't hurt as much. You know, my bowel habits are more regular or more responsive. But right now, unfortunately, there isn't the hard scientific evidence out there that shows in a double-blinded study that we are seeing these improvements. And so really that would be the next step, is for those studies to be taken into effect. And then we'd have to prove enough of a difference and a consistent enough of a difference for it to be something that could be considered to be covered. But I think that's unfortunately fairly far away, because it is so variable with different patients.
Right.
And again, there are some things that don't get corrected with this, and we still have to use our colleagues in the physio world, the physical therapy world, and as well as like urology and GYN that help with some of the other dysfunctions that we see from the changes after babies.
Right, exactly. Well, it's just a wish that I have right now. It's a dream.
It's a common question that I get asked, and it seems like there should be a simpler solution, but unfortunately, as of right now, the insurance companies save money by not spending money. So,
of course, yeah. That's just the way it is. I know. And then just sort of speaking along those lines, and like research and involvement of physiotherapists and other rehabilitation professionals, are you aware of any studies as of right now that have looked at sort of outcomes, differences in outcomes, if they've had any kind of rehab before, and or if they've had rehab after the surgery, and with regards to the longevity of the procedure that was done on them? Are you aware of anything like that that's out there right now?
Sure. So when you asked me that question, I actually had to do a little bit of my research on my own. And there was a study that was published that talked about diastasis rehab prior to surgery, and that people could get with muscular contraction closure of their diastasis. And something that we see during surgery, when the patient is truly relaxed, meaning paralyzed under a general anesthesia, we do see that tends to separate back out. So even though you can coordinate the muscles together and keep them there actively, that passively they do tend to expand back out. I have found in my personal practice, patients who've undergone rehab beforehand tend to have better recoveries.
Okay.
Their muscles are in better shape. They're more able to withstand discomfort after surgery. Because they're used to pulling the rectus together, they don't have as much pain from this big separation that's been separated that now I've tugged together, because they can get it closed or close to closed on their own. And again, patients who use rehab after surgery tend to also recover faster and safer. So I'm a big fan of using physical therapy both before and after surgery for patients that are willing to do it.
Oh, that is wonderful to hear. Especially because I think it's not commonplace for a lot of, I guess, plastic surgeons to be referring out to physiotherapy, or to even consider the role of physiotherapy at this point in this major surgery that people are getting. And simply the fact that it's such a major surgery in the abdominal wall, that the presence of pain itself can really alter the function of the muscles, and that's been demonstrated by research. So let alone sort of being in a period of time where you're not, you know, for several weeks post-op, you're not really doing much. You're very limited in your mobility and what you can actually do in your core muscles. So it would almost seem like the most reasonable thing to sort of educate these women at a certain point post-op on how to reconnect with these muscles that have and are currently being sort of compressed with the compression binder, and just sort of reconnect with them and then gradually strengthen them back up. So yeah, it's really nice to hear that you are referring your patients out, and I'm so happy to hear also that those who are going through that and doing some rehabilitation before and or after are seeing some good outcomes and almost better outcomes from that. So that's wonderful.
Yeah, and I think again, it's a financial thing as well, as
Oh,
obviously,
right.
you know, the visits are usually again not covered, and so so I think that the patient really has to be invested in the process.
Right.
And the other thing that I find is just coordinating motion for when you're not engaging your core, how to use your arms and legs effectively to get out of bed.
Yes.
Toilet, things that we need to do in the recovery process.
Yeah.
And those are things that can be learned in prehab.
Exactly. Yeah.
Before surgery, and then things that can be coordinated after surgery, as well as we do sometimes see some dysfunction because of the hunched nature that patients can be in after surgery, with tightness in the back and shoulders and across the chest wall, and just having somebody work even some passive stretching of you know, opening things back up, because we get into some bad positioning and some dysfunction from you know, again, the discomfort changes our mechanics around the discomfort.
Right, right. Exactly. And there's so much more we could even talk about that, but I'm just going to backtrack a little bit and kind of go over, sort of go back to the topic of the surgery itself. So I know that there are different options. There is, there's open, there's laparoscopic, there's even robotic. And if you don't mind just briefly explaining the differences between them, or like why a surgeon might choose one over the other. And if you're at all aware of differences in outcomes to each of them.
Sure. So the open is the most common. It's probably about 95% of most tummy tuck surgeries and diastasis recti repairs.
Okay.
And because we're removing an excess of skin, we have to make an open incision anyway. And it allows us really great access to the anterior rectus abdominis fascia, or the sheath, which is what we sew. Typically with laparoscopic, these are techniques that are being combined when somebody has a hernia that's being repaired laparoscopically, or if somebody has no loose skin, the laparoscopic or robotic is an option to repair the diastasis with minimally invasive incisions.
Okay, okay.
Plastic surgeons are trained in these techniques, and so they're a little harder to find. And then again, you have to be a great candidate for it. From my understanding, the outcomes can be very good with all of the surgeries.
Okay.
Posterior sheath closure alone tends to have a little bit higher rate of recurrence than anterior sheath alone. And if you think about the abdominal wall, if we're closing this and not the anterior sheath, we're still going to see a little bit of V or coning of the muscles. Whereas when we close the anterior sheath, we don't see that vein on the backside. And so I think that that's one thing. And there are some docs that close both, but the anterior sheath closure is the most common.
Oh, okay. And so just to clarify for those of you who aren't aware of what we're talking about with regards to the rectus sheaths, so we've got these muscles that are on the sides of the abdomen, and they then form what we call, it's fascia, but what they then form are sheaths of connective tissue that go over top and underneath the rectus abdominis muscle. And so there is the connective tissue that's on top, we consider that anterior, and the connective tissue that goes underneath the rectus abdominis, that's the posterior. And the muscles that form the anterior and posterior fascia are different muscles. So in the linea alba where they join, that linea alba is actually created by the different layers of this connective tissue that sort of joins in the center. So different surgeons have different approaches on what they do, whether they do their plication, and we'll talk about what that is, through just the top layer of that connective tissue in the linea alba, or all the way down to the bottom layer as well. And that's basically what Dr. Moenster just described. So that was a really great explanation.
Yeah, and thank you for explaining again the anatomy portion. That's very helpful. So
Yeah. Oh, yeah. Because I know some people just won't even know what we're talking about. So just want to make sure that we.
pictures always help for sure, but it's a common misconception that the muscles themselves get sewn, and even plastic surgeons will say, you know, we're going to tighten the muscles. We're not sewing through the muscle because that would be quite painful and could lead to a lot of injury and bleeding and muscle tears. We're actually sewing the fascia itself because the fascia is usually very strong and very hardy and
Okay.
scar together and hold together nicely without damaging the muscles.
Okay. So are you saying that when you're sort of approximating the two rectus muscles together, the stitching that you're doing, it's not going through the rectus muscle, it's just staying within the linea alba? Is that what you're saying?
Yeah. So we're kind of into the edge of just outside of the linea alba to bring the two edges together to recreate the linea alba.
Okay.
And the goal is not to catch a lot of the muscle for the reasons that I mentioned. So
Right.
occasionally some of the muscle itself does get stitched, but a majority of the muscle is just the edges of the fascia, just outside of the linea alba being brought back together.
Okay. Okay. So the procedure, the diastasis repair procedure, then what that involves is, I guess, bringing the two muscles together and then suturing using various kinds of suturing techniques for in being able to sort of suture the linea alba in a more closed position. And is that correct?
Yes. And really the goal is we're basically just restoring normal anatomy.
Okay.
So as the muscles stretch and you get a diastasis, which is a separation, that is not a natural state, but it is a state that's usually required to grow a baby. And so what the goal is to bring the muscles back into a normal anatomic position.
Right.
There are some doctors who will over tighten, but that again is more for cosmesis. It's not for function. And so the goal is just to maintain or restore normal anatomy. The same as if you tore your ACL, the goal is to rebuild or reconstruct the ACL to normal. It's not to make it abnormal or super normal or extra tight or extra loose. It's just to maintain back.
Got it. Got it. And the stitching can happen along the whole length of the linea alba, or are there times where you might not even do any stitching in regions maybe where there isn't as much separation? Would that be possible?
Sure, exactly. And so typically it depends on, again, where the diastasis is located. A majority of the time, though, we are sewing from the xiphoid process or the tip of the breastbone all the way down to the pubic bones or the bones of the pelvis and around the belly button, because most patients will have some separation all the way around. If somebody has a very limited separation, obviously you could just close that area with a taper into the normal anatomy. But we want to see normal from the top to the bottom.
Okay. So
it's not that isn't that has a diastasis that we don't close, that area is going to end up being extra weak because that pressure from the abdomen is going to go to the easiest place to go.
Right, exactly. Yeah, that makes sense. Which could alter sort of the function of the core if pressure is being distributed kind of unevenly. We're more, or maybe not being tolerated as well in certain areas if there's that discrepancy in, I guess, the laxity that's there. Never thought of that. So, okay, just very basically, so we can understand what happens inside of that procedure.
Sure. So when we're sewing the abdomen, there's a lot of different techniques and different suture types that can be used. So typically we're closing again from the breastbone to the pubic bone and going around the belly button. And the edges of the fascia or of the muscle sheath or covering is being grabbed and brought back into normal.
Okay.
With those techniques, there's typically what we call an interrupted technique, where a single stitch is placed to bring those areas together, and then there's multiple single stitches laid down.
Okay.
What's called a running stitch, where we start at the top and we go down almost like a baseball stitch from kind of the top to the bottom.
Okay.
And a lot of physicians do a combination of those. The benefits of the single stitches is that if one stitch were to pull through or to break, which again isn't super common, but if that is, then the stitches above and below kind of help hold that. With a running, if one breaks, it could unravel, just like pulling a string on a sweater. So we like to have that little kind of insurance system to having a little bit of both.
Okay, great.
And what we see then is different doctors will use either absorbable or stitches that dissolve, or non-absorbable or non-dissolving or permanent stitches.
Mm-hmm.
And again, is a very much a personal preference, and I think you have to take the patient into consideration.
Okay.
A very active athletic patient who is going to be doing a lot of athletic endeavors and using their core a lot may benefit from a more permanent suture where we're not relying on the scar alone to hold the abdomen closed. The stitch itself will stay forever, and that provides additional support. With the dissolving sutures, anywhere from 3 to 5 months, those stitches will dissolve, and the scar is what holds the abdomen closed.
Okay, okay. And I didn't realize it took that long for them to dissolve. So it's a very slow process, which is kind of nice because that's actually how long it takes for that sort of collagen to sort of build up and form that scar over a period of time. So, okay, that's really, really interesting, and it's great to know. And I'm just going to sort of take one step back again, and just so that we're all on the same page here regarding the surgery. So please correct me if I'm wrong. What happens is that there's an incision that's made from one hip bone all the way to the other hip bone. And then that skin is then lifted up so that you have access and you're able to view the tissues underneath that. And then from there, you would begin either the liposuction procedure, or if that's not being done, then what you would start doing is the plication, which is the sort of bringing together of the rectus abdominis muscle and stitching them together. And that can be done from the the xiphoid process all the way down to the pubic bone. And that actual plication can be done either, from what you're saying, either through single stitches all the way down, or it can be done through sort of one continuous stitch. And that the choice of using dissolvable or permanent sutures kind of depends on the surgeon, as well as the person that's in front of you and their post-op goals. And then, so once the plication is completed, then so what happens at that point? And then the belly button, what happens with the belly button?
So the belly button, as long as the belly button is healthy, stays attached to the abdominal wall. So the area and the fascia. And we basically cut a hole around the belly button and it stays attached. Then we'll pull the skin, the excess skin down, and trim away the excess skin and basically just make a new hole for the belly button. Bring the belly button through, suture that in place, and then suture the skin closed. And I know this was another question later on. Typically when we do that, because we've created a lot of empty space, when we lift all this skin up and stick all this skin back down, there's a lot of potential space between the abdominal wall and the skin and the soft tissue.
Right.
That, I tell patients, is like a blister. If you've ever had a burn from the stove or a blister on your shoe, the skin kind of separates from those under layers and fluid wants to form underneath. Physicians will either place drains, which are little tubes that pull fluid out with the compression that helps keep the fluid from forming. So basically pushing those layers to touch so that they scar together and close. Or they'll do what's called a quilting suture or a progressive tension suture. And that is little tiny stitches are placed along the abdominal wall, down the abdominal wall, basically to close that dead space in multiple layers. And you can do a combination of those with or without a drain. And then compression is always part of that.
Got it.
We always want to make sure those layers are stuck together. If there's an extra room for space, fluid will form in between those layers.
Okay.
And that's called a seroma.
And that's called seroma. All right. So fluid buildup is called seroma.
Yes.
And so when we're recommending patients wear compression post-op, then it's not only because of just the need of support for these muscles and tissues and that have now been operated on, but it's also to prevent the body informing unnecessary or too much fluid, like cyst-like fluid, that might collect in the abdominal, I guess, cavity.
Yep. So the compression acts twofold. Supportive garment for the muscles and for the tissue, and then also to get the skin to stick back to the abdominal wall without fluid in between those layers.
Okay, perfect. Thank you for clarifying. And then what would you consider, when would you consider using mesh and not using mesh for diastasis recti repair?
Sure. So typically mesh can be used, especially if there's a hernia. If the hernia is large enough that it's not going to be closed with sutures alone, is a time to use mesh. And then some physicians, if for some reason the fascia is really weak or attenuated, or they don't feel that the sutures alone will be strong enough to hold it.
Okay.
Typically with diastasis recti and using a mesh, we use a dissolving mesh that will dissolve over time. So it again provides a little bit of extra structure and support. And
Okay.
then if scar tissue forms, forming some strength, that mesh will then dissolve.
Okay.
And that is the most common. Now, if a patient has multiple hernias, a lot of weaknesses in the abdomen, a non-dissolving mesh may be considered. This is more of an abdominal wall reconstruction than a normal diastasis recti with tummy tuck. And that again is a little bit different animal and typically a more complicated surgery. I will tell you, I have very rarely used mesh, and it's usually only if somebody has a pretty large hernia that maybe has recurred, meaning they've had a hernia repair once and it's come back.
Okay.
Or they have a weakness that falls outside of my plication of the rectus abdominis muscle that I don't think is going to be adequately held with sutures alone, and then I'll use a mesh during that time.
Okay. And could you speak to the outcomes in using mesh for diastasis recti repair versus not using it?
Yeah. So again, I have had no change in my recurrence, and again, there's no change in recurrence with a normal diastasis.
Okay.
Things that I have seen in my practice is somebody who tries to put mesh over a diastasis, treating it like a hernia, and that typically does not work because again, we aren't putting enough structure where the linea alba has spread.
So are you saying that they would do that instead of the plication?
Yes, and that typically doesn't alleviate symptoms, and it typically also does not close because we're basically just reinforcing or sandwiching a layer on top of the diastasis. And
oh,
so
interesting.
With the mesh, some of the other complications we see, if it's a non-dissolving mesh, there's a little higher rate for infection because again, there's a foreign body in there. And then some of the mesh is a little over-engineered, which is why we prefer an absorbing mesh or a partially absorbing mesh.
Okay.
It's 200 to 300 times the strength of the fascia, and so it's almost too strong. But we can see fibrosis and excessive scarring. And in very, very thin patients with a thin abdominal wall, sometimes they can even feel the edges of the mesh. And that can be a little concerning for patients to have, like, where they can feel those edges.
Right.
And it's so strong, we also don't get the normal excursion or the expansion and the flexion, the mobility that we see in the abdominal wall. You know, they're very agile, they move, they stretch, they twist, they bend. If we put a hard plate on them, we're not going to see that same function. So again, we typically don't like to use a mesh unless, again, somebody has a very large hernia that needs repaired or their fascia has been very damaged from multiple other surgeries.
Okay, thank you so much. That really helps to clear things up for a lot of people, including myself. So, yes, we talked about drains already. We did speak about hernias a little bit. And I'm just wondering, in general, what would be the appropriate doctor to see to address if someone is not really concerned about a diastasis, but they have an umbilical hernia? Who should that person be going to get this hernia operated or fixed?
Sure. So if somebody has a hernia alone, the best surgeon to go to is going to be a general surgeon, somebody who is adequately trained in hernia repair.
Okay.
Most plastic surgeons have also done some form of general surgery, either a full general surgery residency or at least 3 years of general surgery.
Okay.
In doing hernia surgery alone, there are different approaches, again, laparascopic and robotic, and those typically aren't performed by plastic surgeons, but by general surgeons. And so, again, when you look at which hernias are being repaired the most by which surgeons, a general surgeon is typically the hernia expert.
Okay. All right. So, if they have just a hernia, it's probably better for them to see a general surgeon. But now if they're talking about having diastasis and excess skin in addition to a hernia, then that's when they should kind of start looking for consultations with plastic surgeons.
Yes. And there's, again, if I have a small umbilical hernia, I will repair that at the time of surgery. There are some plastic surgeons who maybe didn't have enough adequate training in hernia repair or have not done enough of them in recent years. They may enlist a general surgeon so that the procedure can be done at the same time. And that's something that I think is important to discuss with the surgeon. You know, will the plastic surgeon be repairing the hernia? Do they want a general surgeon to do the hernia surgery at the same time, or perhaps before the tummy tuck surgery? And those are
interesting. Okay.
Mm-hmm.
That's very good to know. So what you're saying is that not all plastic surgeons have maybe adequate training in that, or not enough experience in doing hernias. So sometimes they will actually enlist the help of a general surgeon at the same time to do, if that person is hoping to get everything corrected at in the same surgery.
Yes.
Okay.
And even myself, I've enlisted the care or the help of a general surgeon when somebody has a very large ventral hernia, which is a hernia that isn't at the belly button, but from another surgery, because there was bowel content in there. And so again, it becomes a comfort level and a safety level. And those, of course, safety is number one of the patient. And so you want to be in good hands for your surgery.
Okay. Thank you so much. So, regarding post-op, can you describe what that post-op period will look like for someone who's undertaking the surgery? What will it look like in terms of pain, swelling, bruising, being hunched over? What can they expect?
Sure. So again, we always talk about the normal post-operative course or the average post-operative course, because of course every patient is a little different, and we have patients who at 3 or 4 days look fantastic, and patients who at 3 or 4 weeks are still struggling. Okay. Typically what we see is the first week is always the toughest as far as mobility goes and as pain goes. Typically bruising and swelling start around day 2 to 3. Okay. Some can last sometimes up to 3 or 4 months, and I even have patients who will swell up to a year as their lymphatic system, which is the fluid balance system, gets back into effect. We see different swelling based off of different climates, different activity levels, but you can see some swelling that lasts a lot longer. A majority of the swelling in most patients is that 4 to 8 week time frame. Bruising, again, 2 to 4 weeks for most patients. Okay. Hunched over, again, is something that's very different. In my practice, I don't like patients to stay hunched for too long because I feel like it creates upper back, neck, and shoulder issues, and I don't like that. So we're trying to make things better. We're not trying to create a new issue. And so I have patients be as upright as they are comfortably, and that varies from day to day. Okay. My patients by the 2-week mark are pretty straight when they're sitting or standing. Okay. A lot of times when they're lying down, I do recommend that they're in like what we call a reflex position. So the head up and the legs up, or some people will call it like a recliner position. Right. It can be a true reclining chair. Okay. Or occasionally what I'll tell patients is 2 pillows underneath the back and the neck, and a pillow underneath the knees and the legs. To lift up both ends. Legs to hang down, because again, we don't want blood clots or excessive swelling in the legs. So we want the legs and the knees propped so that the bottom comes up and the top comes up, to kind of like a crunch position to take some of that pressure off of the abdominal muscles. And that typically is for 1 to 2 weeks for most patients. Okay, so 1 to 2 weeks for that. And so what you're saying is you actually recommend your patients to stand up as much as they feel comfortable doing, rather than sort of recommending them to stay in that position to preserve and sort of protect the surgery. Are you saying it might be better actually for them to be as upright as possible as soon as possible? For my patients, that is true. I tend not to over tighten the skin. I tighten it just the right amount for tension. We don't want them to pull the incision apart, of course. And if things are really over tightened, the hunching has to happen. Okay. The belly wall, again, the muscles are sewn side to side. The hunch over is because the muscles tend to cramp or tighten. Got it. When we tighten our abs, we move forward. Yeah. And so I do prescribe a muscle relaxer, the binder, again, to try to help keep the torso upright. And I think those are things I'd rather have people bring the legs closer and keep the back and the chest upright, because again, I'm trying to protect the function of the the thoracic spine and the lumbar spine, the upper and lower back. And I feel like that hunched position causes a lot of problems in the neck, upper back, and shoulders. If somebody's in that position for 2 or 3 or 4 weeks, they're going to have neck, back, and shoulder problems.
Yeah, just adding to the whole mix of things that what they're already going through. It's almost it's almost unnecessary to add more on top of that.
Yeah, we want to keep good spine alignment when we can, and the way to do that is to bring the legs closer to the body.
Okay. And what would you, so I guess going off of that, so you mentioned being in that position. Would that mean that you would recommend maybe individuals to potentially kind of rent a lift chair or some reclining chair? Because I'm assuming they're not going to be able to use their muscles for a period of time. And so like what other sorts of equipment maybe or home setup would you recommend for women post-op?
Yeah, and I think it's really a personal preference. If patients have a recliner already and they're comfortable, I think it's great to use. Some patients don't like a recliner. I can't sleep in a reclining chair. I prefer to be in my bed. And so then again, those extra pillows, if you have a very high bed, you may need some steps that are very sturdy or some boxes. You don't want to use a very small step as you're getting in and out. And then I think using, again, some mechanics that can be taught by our physical therapy is the log rolling technique to get in and out of bed. So you're not using that core to get up. Strengthening of the arms and legs before surgery so that you can push with your arms and use the strength of the legs to get on and off the toilet or in and out of a chair where you don't have to use that, throw yourself forward using that to get in and out of a chair. And so those general health and wellness and muscular use, I think, can really make a big difference after surgery if you're already training your body to do those things before surgery. Having some assistance, especially the first 3 days to a week, is pretty helpful. And what I tell patients, and it's usually a loved one that's helping them, sometimes a mom or a friend or a sister or a husband or a wife, I tell them that you need to move at the patient's pace and let the patient direct how to help them. So some patients want a little bit of support from their back. Others want you to pull on them a little bit. Others want to pull on you. And of course, you want to make sure that things are safe and that you're not injuring new things or the person that's helping you isn't being injured. But there definitely are use of the arms and the legs, I think, are important. Using some log rolling techniques to basically deactivate the motion from the core, which is the part that's really going to hurt.
Yeah. Okay. And just to clarify, just in case, so log rolling is when you're in one position, let's say you're on your back, and when you're trying to roll over or trying to get up, you are not just sort of flexing and doing a sit up, you are rolling over with your upper body and lower body rolling at the same time, and that's what we call it, log rolling, to minimize any twisting and unnecessary and excessive use of the core muscles. And we use that in many different scenarios, and this is one of the most applicable scenarios too, is when those muscles that we don't really want turning on at that time, to sort of let them stay in the background and use all the other large muscles of the body.
And the same thing, splinting or bracing of the abdomen, especially with coughing or sneezing, because those things really hurt. Putting the hands on top of the binder, or bracing with a firm pillow or even a folded up towel in a pillowcase. So you're folding the abdominal muscles. And I think a lot of ladies who've had C-sections were taught these techniques in the hospital to basically support the abdomen. So as you cough or sneeze or Valsalva or put pressure on the belly, you're providing a little external support as well.
Right, exactly. Okay, and so when would they come in, like how many follow-up visits would they have, typically speaking? I think maybe it might be different from surgeon to surgeon. What would that post-op recovery and follow-through look like?
Sure. So some physicians do the next day. I'm not a huge fan of this because I usually think day 2 is your worst day. And I think making them come into your office when they're pretty miserable is usually sometimes a little bit rougher than it has to be. So that's my personal preference. The other doctors do utilize this because typically when things are going not well, if there is a complication, we usually see that within the first 24 to 48 hours. And so for me, I provide access with my cell phone number. My staff checks on the patient to kind of troubleshoot for some of these complications as to whether or not they need to come in.
Okay.
In my practice, I see you at 1 week, depending on how you're doing, I see you 1 or 2 weeks later. And then I usually follow patients about once a month for that 3 to 4 month range as they're going through recovery. More often if somebody is struggling with their recovery process, and less frequently if somebody is doing really well. Or again, if the patient is from far away, we'll touch base, we'll do virtual follow-ups, or we'll do phone follow-ups to kind of talk about the progressions and just make sure that everything is safe and the patient is following the instructions and the progressions of their recovery.
Okay. So let's talk about the progressions of recovery. So what are the, I guess, lifting restrictions? What kind of restrictions are sort of placed on women post-op immediately? And how quickly or soon after do they begin to sort of become less and less restrictive?
Sure, and again, it's of course very individualized. If you take somebody who can't lift 10 pounds before surgery, you don't want to give them a 10-pound lifting restriction after surgery. So, somebody who's an avid athlete who easily can lift a 40-pound bag may be able to lift a little bit more right after surgery than maybe somebody who's a little bit more deconditioned.
Okay.
Typically what we do is we have about a 10 to 15-pound lifting restriction in that first week or two. So this is important for women who have small children. One of my biggest things that I worry about is getting babies or young toddlers in and out of cribs, in and out of pins, and in and out of car seats, because not only are you usually lifting, but you're also twisting, and you have to use quite a bit of core activation for that. Even if the arms are pretty strong, usually they're lifting up or pulling from down.
So it's never like hat on. It's always like this weird, awkward angle.
And again, if you have a feisty toddler or a young kid who's squirmy or doesn't want to be put down to bed or doesn't want to be put in their car seat, which of course is very typical of toddlers, it can be dangerous not only for mom, but if mom has a muscle cramp or a spasm, you could drop baby. And so it could be dangerous for baby. And so those are things that I'm also very, very cautious of initially. For me, I tell moms, you're sitting on the couch or in the recliner, you can hold your infant, you can hold your toddler, they can climb into your lap. Older children can snuggle you, but they have to know mama has a boo-boo and that she's healing. And so you don't want them on your stomach, you don't want them kicking. So, soothing a very, frantic child may be something that somebody else needs to help you with. But if you want to enjoy a bedtime ritual, I think it's something that you still can participate in.
Okay.
Typically that 10 to 15 pounds is for the first 2 to 3 weeks. At 4 weeks, I have patients start some light exercise. My patients are walking the same day. I want them up and walking.
Okay.
Exercise would be things that aren't engaging the core. Walking, maybe some lower body, some indoor cycling, elliptical, those kind of things. Some light weights with the arms and legs, but again, no core exercises.
Okay.
Weeks, I let my patients start planks, front side planks. Not every patient.
Sorry, was that, I'm sorry, just cut out there for a second. Was that at 6 weeks or what?
I'll let patients start some planks, but not every patient's there. At 8 weeks, I'm okay to start some ab work and some core work, including things like crunches and twisting. For multiple reasons. Typically at 8 weeks, we see 80% of healing is done. And also at eight weeks, the scar is very strong, and a majority of the scarring internally is strong. And with ab exercises, we like to do lots of twists and bicycles and knee twists. And we also at 8 weeks see that skin has sealed down all the way. So again, we don't want a lot of excessive twisting in those first 6 weeks, especially because we don't want to create shear forces between the layer of the skin and the abdomen that create fluid.
Right, exactly. And also probably just for people to go back to those things very gradually, because they haven't used these muscles in a very long time, and now they've just been newly operated and maybe haven't done much prehab or post-rehab. You may not want to start with a full sit-up or full sit-up and crunch, and twist, but maybe do them gradually. So that would help.
I tell most patients the 50% rule when you go back. 50% 50% of the time duration, 50% of the reps, and 50% of the sets.
Okay.
As an example, because it's a general example, if you normally went to the gym and did the elliptical for 20 minutes at a level 10 and did 3 sets of 10 for weights with 10 pounds, start with, 10 minutes of elliptical at a level 5 and 3 sets at a level 5. Burning, ripping, tearing pains are never normal. It's normal to have discomfort as you get back into exercise from surgery or injury, and that I don't recommend training back-to-back days.
Okay.
Process, because you want to see how your body responds. Because sometimes doing it, you feel great and you pay the price a day or two later. And then also don't train the same areas back-to-back days during that time as well.
Great,
And
great tips.
and so those are things that I recommend for patients, and then gradually add 10%. And if something doesn't feel right that day, your body is telling you, hey, this isn't right for me today, back off. You can try it the next day, because you're going to see differences as you kind of go up and down. And some days things will feel really great and really easy, and other days they may feel pretty bad.
Mm-hmm. And when you say pretty bad, what do you mean by that? Like pain, more swelling?
Pain and discomfort, more swelling, you know. And so you know, you want to kind of use, again, if you're perceiving the exertion of something you did the day before was a 3, and then you go to do it 2 days later and it's an 8, that may be your body's way of telling you, hey, I need to back off, I'm not ready for this today.
Okay.
And that's very hard for the really athletic patients, because
I know. Yeah.
themselves and they're used to being in a little area of discomfort.
Yeah.
And so for them, I think having a little more structured program is important. And again, that's something that you can work with a therapist, you can work with exercise professionals. And then again, you have to be very honest with yourself during that process. But it can take 6 months to a year to get back to your pre you know, surgery prowessness from athletic standpoint. But I also have a lot of patients who are even more effective in their athleticism, because they do have some more structural support, and the core is coordinated again when they're using those muscles, and so they can actually make very good gains, but it does tend to be slow.
Yeah.
It's the injury thing. You know, if you tore your ACL, you wouldn't go back to running 5 miles a day the first day your doctor said it was okay to exercise. You know, you're going to take a walk around the block and see what happens.
Yeah, exactly. And just a point to mention there is, because, you know, some women probably feel okay. I'm sure everybody's recovery is different. So some women probably feel fine. And so they might just think, okay, I'm going to push myself a little bit today. And then they do. And just like you said, maybe they experience more pain and swelling the next day. In a way, that's a good thing to experience that, because it's feedback that your body's giving you. Doesn't necessarily mean that you've done any harm or damage, but it's just feedback there. And it's interesting because some people will have, they won't feel anything at all, no pain, no swelling. They'll go back to their workouts and they're still feeling fine, not getting any additional, not any more symptomatic like after doing that. So in these cases, I feel like we would still need to be a little bit more, not restrictive, but just like let them know that you're still quite early in the post-op period, and just do things gradually. You'll never regret doing things gradually. Like you're going to get there. You're going to do what you want to do, but just do it gradually, even if you feel fine.
You always want to scale back, and then you want to work through the progressions, because again, if you feel really good, you don't want to damage. This is a big investment in your time, your energy, and your money. You don't want to damage anything or have a big setback that again cost you weeks or months to kind of getting back to normal. And I see a lot like with extension exercises, some of my yogi patients, there's certain things with a really big arch, things like wheel or bridge, that don't feel good for 3 to 6 months, you know, because it's really a big stretch. And so I tell them to start with getting on like a physio ball and just lean back.
Just a little bit of leaning back.
Just where the shoulders go a little bit behind, and just and say, okay, that feels good. And the next day, try to lean back a little bit more. And it just has to be a gradual possession before you go into that full bridge.
Perfect.
And again, maybe doing a bridge on a ball so that you have some support. So if something happens, you're not going to collapse and injure the back, neck, or shoulders.
Fantastic.
Very slow progressions to get back to whatever it is that you want to do. And that could be carrying your kid and pushing your groceries around. You know, it doesn't have to be true athleticism. It can be your normal everyday function of meals, carrying a laundry basket that's full, getting a child in and out of a car seat, or gardening, or whatever your hobbies may be.
Yes. There's so much that I could talk to you about right now regarding all of this, but I think we'll have to just
do another interview.
Okay, amazing. I would be so happy to do that. So I guess just sort of moving along with regards to complications, and we were sort of talking about that, short-term complications, some pain, swelling. you might have bruising and being hunched over and those sorts of things. Are there any more complications that you can see for just the initial immediate post-operative period?
Sure. So short-term complications are a lot of the things you mentioned. The other things that we worry about are seroma, that collection of fluid,
Okay.
bleeding, which are usually within the first couple of days. So
Okay.
excessive bleeding, infection, which again is fairly rare, but something that we do watch out for. And something that we see a little more often is what we call a wound healing complication, meaning an area of the scar that isn't healing as well as the other areas or is slower than the other areas. And this can be from tension. This can be from the binder rubbing. This can be from other surgeries that have disrupted the blood flow to that area. And so those are things that we watch for. And that's part of the reason kind of for that follow-up to check those things. And the reasons why in my practice, again, I ask you to change the dressing every day so that either you or whoever is helping take care of you can see it and say, hey, this looks really different. Maybe this isn't something that's normal, and they can contact the physician. So those are the things that we see most likely early. And you're going to see asymmetries. You're going to see lumps and bumps. You're going to have funny feelings. Numbness is almost 100% guarantee in the short term. It can be a long-term complication as well, but usually there's going to be areas that are pretty numb, and those are normal, common, short-term, both complications and expectations.
Okay. Okay. And then what about anything long-term? Any long-term complications?
Sure. I think some of the most common long-term complications, again, is what we call a chronic seroma, so a fluid collection that forms that is long-term. Poor scarring is something that can be a long-term complication, what we call a hypertrophic scar, or a scar that has spread outside the normal scar, or a keloid scar, a scar that is raised and spread. We see what we call dog ears, or sometimes it's called a raised cone deformity. It's like a little corner at the end of the scar, and those sometimes have to be revised. Asymmetries, again, it's not uncommon. None of us are perfect from side to side, even our bellies, to see some of those little differences, but they can be concerning to women. And then again, permanent numbness or chronic pain, which is very rare, but it can happen with some patients.
Oh, okay.
The surgery itself, it's very rare, but I have had one patient in particular that had pain after surgery, and we really couldn't quite figure out what it was. We sent her to a pain specialist, and it's probably an internal scar tissue issue that has given her some discomfort in her belly, especially with like a twist and a bend.
Oh, okay. All right. And so you were talking about the idea that, sometimes a scar may not be symmetrical, and some areas might be pulling more compared to others, just depending on the rate of healing. And when would it be appropriate to maybe go back to the surgeon if you have a concern of the scar, if there's maybe an asymmetry? And would that be, would you do another surgery to fix that? Like, what would be the course of action?
It really depends on what it is. I think anytime you have a concern about, is this normal or is this progressing right, I think you need to bring it up to your surgeon. There are times when scars need to be revised very, very early. For instance, if there's an area that actually separates or breaks down where the scar opens, that needs to be addressed a little bit sooner. Sometimes we will do wound care, meaning dressing changes, to give that some time to calm down before we'll do something. And then there's times where we don't recommend doing anything with a scar until a full year has passed. Okay. It does take us a year for a scar to mature all the way, for all the redness to go out, for the collagen to reform and reorganize. And so there's times where we do wait a little bit longer for things to settle out. And scars will look different at different times, with different bruising, with different areas of swelling. And so it's variable, but I think it's one of those things you need to have an open dialogue with your surgeon about, is this normal? If this doesn't correct out, what are my options? And so that you just have a very clear-cut plan of what's going on. And most of the time, it's normal to see these things and they work themselves out, but occasionally things do have to be done. And that varies between, most of the time, the 3 months to a year range for revision.
Okay. And are these revisions an additional cost to what they had already sort of invested in, or are they usually covered as part of that initial investment?
Sure. And so that, again, is something that I think that's important to talk about. And it's something that I talk with my patients about. Typically, if there is a complication from the surgery, not just that, hey, I'm unhappy with how this looks, but it's normal. I typically don't charge a patient to do a revision. However, if I have to go back to the operating room, there is a charge for the facility or the OR, the hospital, and the anesthesia. If it's something that I fix in my office, sometimes there's not a charge.
Okay.
There are things though, if for instance, somebody has had a surgery and they gain or lose an excessive amount of weight from the day of the surgery, we're going to see differences in how the skin looks. And so if there has been major weight changes, sometimes that won't be covered. And so I think it's important to discuss the surgeon's revision policy with the patient. Sometimes they'll do revisions if it's within the first 6 months. Usually these aren't like 10 years ago, I had something done and now I don't like how it looks. Typically those things aren't covered. It's considered another surgery. And then there are some surgeons who every revision has some sort of fee. And so I think that's, again, something when you're in a consultation or researching surgeons that you ask the surgeon.
Okay, that's very, very helpful. You mentioned that if there might be a change in just a bodily change or an increase in weight after the surgery, one of the questions that was, again, one of the most common questions that I got was, what if I get pregnant after surgery? So is it possible to get pregnant? Do you recommend that patients try to be finished having their kids and then go for the surgery? And so I'll just sort of hand that over to you. What would you?
Sure. So I think most plastic surgeons would recommend that people are done with their childbearing before they have a tummy tuck surgery. However, there are times when, again, your life is not planned out 100%. Sometimes people remarry or they have whoopsie babies. And so you can get pregnant after tummy tuck surgery. Some things that are important to know is typically most people don't end up as severe as they looked before surgery. Their diastasis doesn't separate out as much as before surgery because it's been reinforced. But it's important to talk with your obstetrician about this because there are some rare late effects that can cause some intrauterine growth restriction. So the baby, because you can't stretch the abdomen out as much, may have to be monitored a little closer for growing. But I have patients who have gotten pregnant after tummy tuck for various reasons and have perfectly normal pregnancies and perfectly normal children. It can undo some effects of the surgery. So there may need to be a revision or a redo of certain aspects of the surgery after baby if that's desired. And it is safe to get pregnant. We just don't recommend it because it undoes some of the effects of the surgery. So when you're making a big financial investment, you don't want to spend $7,000, decide to have a baby the next year, and then you have to have a redo a year or two later. So those are really kind of the important things. And I tell patients, we all fluctuate in weight. And if we stay within about a 10-pound range up or down, you're not going to see major changes in the surgery. And typically we want patients at a healthy or a stable weight before we do surgery. So, and I'm very upfront and honest with folks. And I will say to them, yeah, maybe you have this goal weight in mind, but is it really feasible and obtainable? And is this something that you can maintain with a healthy diet and lifestyle? And if not, you want to do surgery where you're at a weight that is kind of your normal, stable weight. And as long as it's not too high that it puts you at excessive risk for complications with the surgery and anesthesia, I think that's really a safe place to do it. We don't want people crash dieting down to get to a goal weight, and as soon as surgery is over, it's going to go back up. They're going to lose some of that result.
Got it. Okay. Would there be a reason why you wouldn't do a surgery on someone? Like I can kind of gather from you who the ideal candidate would be. But is there someone that wouldn't then, like you know that they probably could get the surgery done, they have a diastasis, but for some reason you're not going to operate, you would choose not to operate on them?
Sure. Anybody that has comorbidities that put them at too much risk for surgery. So the benefit of surgery is outweighed by the risk of surgery. Somebody who has severe heart or lung issues where the surgery itself could be dangerous or life-threatening. Somebody who is too overweight for surgery, that it would put too much stress on the heart or they're not going to get a good outcome. And then the biggest thing is somebody who has reasonable expectations.
Okay.
If somebody comes in and they say, I want to look like insert celebrity here, and you really can't perform that for them, or that's not what they're going to get with this surgery, they're not really a good candidate for the surgery. And part of that, again, is that open dialogue of here's what I'm going to do and can do for you, and here is what is going to be the outcome. The other thing is if a patient seems like they're not going to follow the instructions for a post-op,
Okay.
they're going to go back to doing too much activity too soon, or they're not going to be able to comply with follow-ups, or they tell you straight out, I'm going to smoke and not wear compression. Well, you're not going to have surgery. Smokers are not good surgical candidates.
Okay.
The nicotine in cigarettes and nicotine products constricts the blood vessels in the skin, especially the superficial blood vessels in the skin, and can lead to a lot of wound healing complications.
Right.
And so there are other medical conditions that may predispose people to complications that would make them a good candidate. And part of that is part of that research and that being open and honest with your surgeon, and then them evaluating the whole picture for the individual to say you're a good candidate for the surgery is safe to do and is worth doing.
Okay. So, and I guess I didn't ask this yet, but I kind of gathered, but I want to make sure that I'm not just assuming that people know the answer to this. Who would you consider to be the ideal candidate for a surgery?
Sure. So for a tummy tuck surgery, it's typically somebody who has either had a lot of weight loss, who maybe genetically is predisposed to excess weight gain around the abdomen, extra skin around the abdomen. There are people who are born with a diastasis. There are men that have diastasis. They've never had babies. And then somebody who has extra skin, who has loosening of the muscles, who is has a healthy lifestyle, who doesn't have a lot of medical problems, and is a non-smoker. Those are really, and then has reasonable expectations for the surgery and is willing to work with the pre and post-operative plan. That's really the ideal candidate.
Okay.
And then somebody that, again, you can have an open dialogue with. You want to be able to communicate well with your patients and your surgeon, so that if there are complications that arise or questions that arise, you feel like you're being responded to, obviously from both sides of this, because I've sat on both sides, being a patient as well as being a physician, and you want to make sure that that communication line is really open so that you can have that dialogue, so that you're not afraid to ask a question, or that you're not afraid to get a truthful answer.
Okay, thank you so much. So that just takes me to some of my final questions here. You just mentioned about having an open dialogue with your surgeon, and asking questions, and being comfortable enough with that surgeon to ask questions. So what is your advice for women who are trying to seek out a plastic surgeon for them? What are some of the things they should be maybe asking the people that they're having consultations with? What are things they should be looking out for, maybe, and even like research and resources that they should sort of be aware of in this initial kind of when they're just exploring the idea?
Sure, and I think it's a very hard thing because, of course, there's no one who's perfect for everyone, and I think the important things, you want to ask about training. You want to make sure that they're board certified. You want to ask about, is this a procedure that you do regularly, or how many of these have you done? You may want to look at their before and after photos. Before you go in to see the surgeon, you may want to look up some reviews of the surgeon, things like Google and Health Grades and Yelp and Real Self. Have patients who are giving feedback on their experience. And if the surgeon has a lot of good feedback about their communication skills, about their surgical outcome, about their bedside manner, about even the staff in the office, you want to ask, where will the procedure be performed? Is this something that's going to be done in the office? Is this something that's going to be in a surgery center or a hospital? Who will be providing the anesthesia? Is this a general anesthesia, local anesthesia? So those are things that you want to ask. We talked about asking about the revision policy. You want to ask about the price up front. You want to ask about the follow-up, what the follow-up plan is.
Okay.
So those are things that should be covered either by the surgeon or their staff during your visit. If
Okay.
they're not, those are things that the patient really needs to kind of bring up and say, hey, you know, I'm curious, if I do this surgery, what's my follow-up process going to look like? How is my recovery going to be? What are going to be my restrictions? Or, you know, when can I get back to my job sitting at a desk or working construction? Because
Okay.
that's a very different source, you know,
Yeah.
based off of your normal active lifestyle.
Mm-hmm. Right. You mentioned one of the questions for them to ask is, are they board certified? So this is actually something that I personally didn't even recognize. You know, just like a plastic surgeon versus a board certified plastic surgeon. What is the difference, and why is that important?
Sure. So when with physicians, and of course, I'm mostly speaking with the United States because that's what I'm most familiar. And I know in different countries there are some different rules and regulations. But typically, a board certification verifies that the surgeon has met the minimum requirements to call themselves board certified. That typically means that they've been in an accredited training program, so that they have met the minimum requirements of the number of surgeries performed. They have passed a minimum requirements of testing education. They have been evaluated by people who have been in the field for a long time in those surgeries for proficiency. Then typically for plastic surgeons, there's an additional written test to test general knowledge about the subject, as well as what we call an oral exam. An oral exam is a combination of questions of unknown questions, again, testing general knowledge, and they also review your cases. So you collect cases for 9 months with pictures, with op notes, with the pre and post-op visits, and you submit those anonymously, so all the patient information is erased. And people who have been in the field for a long time, our examiners, go through that and make sure that you're meeting the standards of care.
Wow. Okay.
After you have done those things, then you can be a board certified plastic surgeon.
Oh,
Then
wow.
in addition to maintain your certification, you have to complete a certain amount of continuing medical education that is also credentialed by governing boards for medicine to make sure that you're maintaining knowledge and skill in that area. Calling yourself a plastic surgeon or a cosmetic surgeon without that may mean you've met some of those elements, but you haven't met all of those elements.
Wow. Okay. Yeah, that is so important, I think, for people to know, because yeah, there are doctors out there who are happily and willing to do surgeries and abdominoplasty surgeries, and even, but they may not have all of these credentials and the training that vigorous sort of credentialing process that needed to be done, and it really just sets you guys apart, and really should be the people that are sort of really sought out for this kind of procedure. So that's so important.
It is. And the other thing that I failed to mention, because I'm a younger surgeon, and even though I'm board certified, there's a period of board eligibility. So because it takes time to pass these tests and to collect these cases, you may be board eligible, which means that you are on track, but you haven't gotten there yet. And so it's also something that I think is good for patients to be aware of. If somebody says, I'm a board eligible plastic surgeon, it means that I'm on the path, but I haven't quite made it there yet because I haven't finished all of those pieces to the puzzle.
Wonderful. That is such great information. Okay, that covers a lot of what
it does. It definitely
covers
does.
a lot. So maybe just one last question for you, and you've mentioned this already, but maybe one or two, or whatever amount that you can give. What resource would you have for women who are trying to look for plastic surgeons, like any websites that you would recommend them to go see and
Sure. Some of my favorite things, I think Google is very legitimate for reviews because they have very good algorithms to make sure that these are real reviews. Now, every doctor can get bad reviews, but you need to look at the generalized process of those reviews. Okay. Real Self is actually kind of a nice website. This is a website that is patient driven. So patients voluntarily go on and post information about the procedure. They post information about the surgeon. And then there's doctors that give feedback in. So if a patient asks a question, there are doctors that will type back in their answer. And so these are doctors from all over the country that provide education and resources.
Wow. Yeah, that's great.
once you've kind of narrowed it down, then I think you should go to the doctor's website. You'll find a lot of information about the procedures they perform. It usually has a before and after gallery. Usually has a lot more information so that you can learn some of the things that we talked about that you should be asking for surgery. Sometimes it'll even lay out what to expect before and what to expect after, how they're certified. Sometimes there's a link that you can click to show that they're certified. And I think those are things that are kind of part of the good education process for patients in selecting a surgeon. Obviously, I think using friends and family's recommendations is a good place to start. If somebody had a positive experience, you know, that very interpersonal connection of saying, hey, I went to Dr. So-and-so and they were great and I was treated well and I liked my outcome. And so I think those are all definitely places to start with resources. I think, you know, Facebook and Instagram and social media are good places to kind of get to know about surgeons, but I also think that these are very small snapshots, and they're usually driven by either the physician themselves or by the practice itself. So I think it can be a very single-sided view. So I think you have to be cautious of those things. Although it's a good way to kind of get to know those things and see some of that, but I think you have to realize that that's only coming from one source.
One side, exactly. Yeah, and that website, Real Self, you had mentioned that to me a while ago, and I did not know about this website, and I think it's really a great place for women to go and get that information. I think it's a really useful website for people to.
Yeah. It is. It's something that I participate in, and some of my patients have participated in. And some of my patients will come in and say, you know, before I came in, I was on this website, and these couple questions came up, and I have those questions, and they'll be able to ask me.
Yeah.
Because there is a lot of variety in how surgeons do things and how we do things both before and after. And part of it is in our hands. That's how we find we get the best outcome. And so sometimes patients have questions like, why do you do it this way? And I think it's important that you can explain why, not, well, just because I've always done it that way, but I find that doing it this way gets me this result because.
Right. Okay. Well, Dr. Moenster, thank you so much.
Oh, you're so very welcome.
For being super generous with your time and just answering all of these questions. We covered a lot of them, and I think it's really going to be helpful to the people who are watching. And really, this was for them because, again, we're trying to put out information out there that is accurate, and there's no better way of doing that than going right to the source. And so thank you so much for being a part of that.
Well, thank you. I'm happy to be here. And I think education is really important, both for patients, for other healthcare providers, and people, again, in the health and wellness industry, about knowing a little bit more, because I think there are still some misconceptions about how things happen or why we do things certain ways. And I'm always happy to help answer questions. Again, my Instagram and Facebook, which are at Dr. Jamie Munster, are places to follow where I try to continue education. And again, at my website, which is www.dermplasticszaz.com.
Okay, and I'll have links to those in the bottom of wherever this video happens to show up. If not, like, just sort of encrypted right on top of the image here. So you guys are going to have that as well. Again, thank you so much, and I hope you have just a wonderful week ahead.
Thank you. Thank you for letting me participate. It's been really fun.
Great, amazing. Okay, thank you.
Bye. Thank you. Bye-bye.